So the last thing we discussed yesterday was on adrenal gland disease, okay, and we talked about Cushing syndrome and Addison's disease. So today there is one more area of adrenal disease that we need to cover, and then we move on to diabetes and various other uncommon endocrine diseases like parathyroid gland problems, etc. Right now, so this MCQ is on pheochromocytoma. Right now, it's very important to remember that. So these are little MCQ points that you need to remember that we like to ask you at exams. So as you know, pheochromocytoma is a adrenaline, noradrenaline secreting tumor. There is a 10% rule for pheochromocytoma. You might have heard this before, right? And the 10% rule is that pheochromocytomas are 10% in 10% they are bilateral. In 10% they are extra-adrenal. So remember, the pheochromocytoma tumor can occur anywhere along the sympathetic chain. And in 10% they can be malignant, right? That's a very rare condition, and it's a very dangerous, nasty situation to be in actually. So this is this sort of 10% rule that we like to ask you. Right, so the first statement is sorted when you see that point. Now remember that the classical presentation of pheochromocytoma is with these paroxysms, unprovoked, right? Very sudden episodes of palpitations, headaches, and sweating. Remember that people with pheochromocytoma can also present with hypertensive emergencies, right? And that is also a very recognized presentation. Now, remember that you need to remember that there are certain precipitants that can trigger off a pheochromocytoma episode or crisis. And one of the famous ones is pregnancy, right? And also when you manipulate the adrenal glands during surgery, and there are certain medications which I have listed here, which can also trigger off a pheochromocytoma crisis. So there's a classical triad of symptoms. Remember, that is the most important thing to remember, right? And they come without warning. The word we use for that is these are paroxysmal episodes. Right. So second statement is true, and third statement is also true. In pregnancy, we know that these episodes can be exacerbated. Right. Now, pheochromocytoma is very, very difficult to diagnose. It's extremely difficult to diagnose. But if you suspect somebody to have a pheochromocytoma, the first thing to demonstrate is that there is excess of catecholamines in the circulation. Now, it is very difficult to measure catecholamines directly, but you can measure the breakdown products of catecholamines, right? These are the metanephrines. And commonly we do this in urine. But remember, all of the metanephrines can also be measured in plasma as well, okay? So, Lanka, we usually do the urines, but it's better if you can measure these directly in the plasma. Once you have demonstrated that there is elevated catecholamines and catecholamine metabolic products, the next challenge is to find where the tumor is, right? And that we use contrast CT or MRI or certain advanced forms of imaging like PET scans, right? So that's very important to remember. So measurement of urinary VM is not really the gold standard for diagnosis. The actual best measurement that you can do is plasma metanephrines. That is the best investigation you can do. Urinary VM is good, but it's not perfect. And it can be affected by various food substances, right? And there's a very strict protocol in which you have to follow when you're doing these tests also. Now, for pheochromocytoma, the standard management is to take the tumor out. That is the standard management. So surgery is the standard management. This is a very difficult, complicated process. But in the interim, until the patient undergoes surgery, it's very important to control blood pressure. And it's very important that you have to block both the alpha and the beta receptors, right? And we usually use an irreversible alpha blocker in combination with a beta blocker, right? So that is the usual standard of treatment for managing hypertension in these patients. So you use an irreversible alpha blocker and then on top of that, a beta blocker. That's also an important point to remember. So you never give beta blockers alone for managing hypertensive crisis because actually it can worsen the situation. right? The mechanism is not important because the exam is next week, but remember that you use a irreversible alpha blocker, and then the drug we use is something called phenoxybenzamine if you're interested. That is an irreversible alpha blocker, and then you also block the beta receptor on top of that. Right. Okay, right. Any questions about that? Pheochromocytoma. So these are MCQs that can crop up in your paper. Right. Now, next we move on to Conn syndrome. Now, Conn syndrome is a specific term which we use for a mineralocorticoid secreting tumor in the adrenal gland. Okay, so Conn syndrome is a specific term for a mineralocorticoid secreting tumor in the adrenal gland. Okay. Now, how does this present? Conn syndrome presents again with hypertension because, as you know, when you have excess of mineralocorticoids, the patient has more salt and water retention, right? And then the blood pressure goes up. So hypertension is a common presentation of these patients, hypertension. Another thing that happens when the mineralocorticoids go up, right, is that I told you guys salt and water retention, but also excretion of potassium, right? So there is active secretion of potassium out of the kidneys, right, into the renal tubules. So active secretion of potassium. Apart from potassium, there is also secretion of hydrogen ion, hydrogen ion. So they also get, so the hypertension is accompanied by hypokalemia because the potassium is now being actively secreted out of the body, right? Actively being secreted out of the body. So they get hypokalemia. And also because the hydrogen ions are being actively secreted, they get a metabolic alkalosis. So that's another common presentation. So hypokalemia, metabolic alkalosis. Now, that sometimes the hypokalemia is quite bad and they present with proximal muscle weakness. Okay, so this is something that I have taught you, that sometimes the hypokalemia is so bad, they present symptomatically with proximal muscle weakness. Right. Okay, now, right. So this is the key, these are the key points that I just went through. Right. Hypertension, hypokalemia, metabolic alkalosis. Right. Okay, right. Now let's look at the MCQ. Conn syndrome, peripheral edema is characteristic. Now, I already told you that there is salt and water retention because of the high mineralocorticoids, because that is action of the mineralocorticoids. They reabsorb sodium and water, salt and water retention. But for some unusual reason, these patients do not develop edema. Even though they retain salt and water, they do not develop edema, right? There is a physiological mechanism for this, right? For some unusual reason, it doesn't reach that level of edema, right? Right? So peripheral edema does not occur, which because there's salt and water retention. But due to an unusual mechanism, it doesn't manifest. Hypokalemia is associated, which is true. I told you that they get a hypokalemic alkalosis. The reason for that is they have active secretion of potassium and hydrogen ion, right? And I also told you about the alkalosis, right? Now, how do you diagnose this? So again, the first thing to do is to ensure that the mineralocorticoid levels are high, okay? And aldosterone is the thing that we can measure easily, okay? So we measure the aldosterone-renin ratio. That's very important. Please put a star down there. Aldosterone-renin ratio, always measure the aldosterone with the renin because they are closely linked, right? They are very closely linked. So you always measure them together. There is no point in just measuring the aldosterone. So you have to always measure the aldosterone-renin ratio. And in Conn syndrome, there will be increased aldosterone-renin ratio. Right. So it's a useful screening test. Once you demonstrate that there is an increased aldosterone-renin ratio, you have to image the person with a CT scan or MRI scan is becoming much more popular nowadays because these tumors are extremely tiny and small, very difficult to find. So MRIs give you better information. And that is what you do. And the treatment again is surgery, right? And until surgery, you need to manage the hypertension, and the best drug to do that is obviously spironolactone, which blocks the aldosterone receptor, right? So that is excellent. That is an excellent way of managing their high blood pressure until you do surgery. So that is Conn syndrome. So all the 5 MCQs we have discussed now. Okay. Right. So Nuwand is asking an important question. So there is this, sorry. Sometimes, rarely these patients with Conn syndrome present with polyuria. There is a slightly different mechanism for that one. I don't think you need to worry about that. That is a problem with the renal tubules and something happening to the renal tubules. Again, there is a possibility they can present, but it sounds unusual, because they retain salt and water because of the aldosterone effect. But there's another slightly different mechanism that causes a renal tubular problem. Again, then Sachit has asked, so Sachit, for aldosterone-renin ratio, so to diagnose Conn syndrome, you have to use the hormone level, plus you have to do the imaging, right? So it is, so you screen them initially with this, and there are other tests for Conn syndrome. Salt challenge test, there are other diagnostic tests, but aldosterone-renin ratio is a reasonable screening test. To be confirmatory, to have a confirmatory diagnosis, imaging and all of the things come into play, right? And there are some other dynamic tests to test the aldosterone axis also, which I didn't mention, which are rarely done, right? Salt loading test, okay, fine. Okay, now let's move to diabetes. Now, diabetes we discussed as a long case discussion, so we went through the various types of causes of diabetes, right? Now, apart from the classical type 1, type 2 diabetes, you also have various other specific types of diabetes, some of which are genetic, and also gestational diabetes, which you have been taught in obstetrics. Now, obviously, there is interest in the differences between type 1 and type 2 diabetes, which I have summarized in this table here, right? This is something that we like to ask you at the exams. Can you compare and contrast type 1, type 2 diabetes? Now, as you know, type 1 diabetes, the main pathology problem here is that there is destruction of the islet cells of the pancreas, right? And there is absolute deficiency of insulin because of this, right? That is a problem there. In type 2 diabetes, what you get is insulin resistance, right? That is what you get, right? Insulin resistance. So type 1 diabetes, type 2 diabetes. That is the main difference in the pathology that occurs, okay? Now, as you know, type 1 diabetes is an autoimmune destruction of the islet cell. So they have antibodies to various components of the islet cells and also to insulin itself, right? So like GAD antibodies, islet cell antibodies, insulin antibodies, so lots of autoantibodies which are floating around in patients with type 1 diabetes, right? And they are associated with HLA-DR3 and HLA-DR4, right? That is something again that we like to ask. Right. Whereas type 2 diabetes, the main thing, as I said, is insulin resistance, and there is no specific HLA association. However, there is actually a strong genetic association, but it's a multifactorial genetic association. Eka gene එකක් දෙකකින් කියන්න බෑ, right? So there is a genetic association, but there are various multifactorial elements in that genetic association. Okay, so let's go to the MCQ. So type 1 diabetes associated with HLA-DR3 and HLA-DR4 positive, that is true. Antibodies to GAD are usually found in type 1 diabetes because they have a lot of autoantibodies in their circulation. So apart from GAD antibodies, they also have anti-insulin antibodies, anti-islet cell antibodies, right? And various other ones as well, right? Okay. And you can get antibodies to various components of insulin also in these people. Okay. There is no genetic susceptibility for the development of type 2 diabetes. Is false, right? There is actually a strong genetic component there, but it is not one or two genes. There are many genes which are involved, right? Okay. Now, if you take the difference in presentation between type 1 diabetes and type 2 diabetes, type 1, as you know, they are younger, right? They present with weight loss, right? And they usually present with diabetic ketoacidosis, right? That is the usual person, young patients who have weight loss, right? Polyuria, the classical symptoms of diabetes, and they come to hospital with diabetic ketoacidosis. Whereas type 2 is different. Type 2, actually, type 2 diabetes is often diagnosed as a routine finding. You just screen for it and find it, right? And it is associated, as I said, with insulin resistance. It's a hallmark pathophysiological feature of type 2 diabetes. So this comparison and contrast between type 1 and type 2 is important not only for your MCQ papers, but also when you have a patient with diabetes for history taking an examination, then again this discussion will be important, right? Especially the patient is relatively young, you need to argue and say what type of diabetes do you think it is, right? Okay. So how do you diagnose diabetes? So here I have listed the sort of diagnostic criteria, right, which you all should know at this point. We went through this in the long case as well. Right. Okay. Okay. Right. So true or false regarding diabetes? OGTT is essential for diagnosis. Is false, right? OGT is just one of the tests that we use for diagnosing diabetes. Right. Okay. Now, before I come to the second, third, and fourth statements, let's go to the last statement, which is the relationship with diabetes. RBS cannot be used in the diagnosis of diabetes, usually not, except in the situation where they present with a crisis, right? A complete emergency of diabetes. Then, of course, the random glucose can be used, right? So they should have very clear evidence, symptoms, and they present in with a diabetic emergency, like diabetic ketoacidosis. But otherwise, the standard measures we use are HbA1c, fasting glucose, and the OGTT. This is the standard ones. You can use a random glucose to diagnose, but then there has to be very, very clear, firm evidence of hyperglycemic symptoms or a hyperglycemic emergency like diabetic ketoacidosis. Okay. Now, sometimes, Lamai, we also use various autoantibody profiles, not to diagnose diabetes, but to say, is this type 1 or type 2, right? We sometimes use that as well to differentiate, right? Now, C-peptide is an important thing, right? Now, C-peptide, as you know, is the byproduct that is released when insulin is formed. Right? So, when there is insulin deficiency in type 1 diabetes, there is no C-peptide. Now, in type 2 diabetes, what is the problem? There is insulin resistance. That is the main problem, right? So actually, in the initial phases of type 2 diabetes, the insulin levels go up, and so do the C-peptide levels, because they go hand in hand, parallelly. So the C-peptide levels also go up. So in the initial stages of type 2, because of the insulin resistance, the insulin level goes up because the body is trying to overproduce insulin to overcome the resistance, and the C-peptide level also goes up as a consequence. So those three MCQs are sort of diagnosis and classification related points, right? Now, how do you monitor glycemic control, right? And we talk about the HbA1c. HbA1c is used to both for the diagnosis as well as monitoring of glycemic control, right? And usually it reflects the last, say, 4 to 6 weeks of control, right? That is the usual standard. There are various things that can affect the HbA1c, right? I'll send you a table of the various conditions that affect the HbA1c later. It's also important for MCQs. Remember that anything that affects the red cell lifespan can also affect the HbA1c, right? Because anything that affects the red blood cell lifespan, if the red cell dies earlier, the HbA1c will be lower because it doesn't have enough time to glycosylate, right? Okay. I will send that over. Right. So any questions up to now? Now, when we're talking about diabetes in the long case, I went through the management with you in absolute detail. So I'm not going to re-explain that. Let's straight go to the MCQs. Right. And I hope that you remember things that I taught you for the long case here. Right. So true or false regarding management of type 2 diabetes, sulfonylureas are considered first-line therapy. That's absolutely false, right? So please write that down if you can't remember. The first line therapy for diabetes, type 2 diabetes, is metformin, and there is no doubt whatsoever about that. All the guidelines all over the world agree that that is the first line drug for type 2 diabetes, metformin. Metformin. Right. Now, talking a little bit about metformin here, right? As you know, metformin, there are only a few contraindications for metformin, and one of them is end-stage renal failure with a GFR of less than 30. That is a contraindication, right? But it's not contraindicated in all patients with CKD, only if their GFR drops below 30. And the reason for that is metformin is known to precipitate lactic acidosis in patients with end-stage renal failure, right? So that is the problem, and that is partly why it is contraindicated. So metformin is an excellent drug, as you know, and it is the first-line drug for diabetes, type 2 diabetes. And metformin has a wide range of benefits, and it helps the person to lose weight. That is an added advantage of metformin. So it improves the insulin sensitivity. Right? That is the most important action of metformin. Improves the sensitivity to insulin. Right. So what about sulfonylurea? I told this during the long case that sulfonylureas can be used as second line, especially in places like Sri Lanka where we are resource limited and we don't have access to these new drugs like GLP-1 agonists, DPP-4 inhibitors, and SGLT2 inhibitors. Right. Okay. Right. So somebody's asking important question. First line therapy, is it medical nutrition therapy or drug therapy? So at the moment, current consensus is that for diabetes, we start this at the same time, right? So we start the sort of dietary lifestyle changes with metformin. So still metformin is first line, right? It's very, very rare that we give a trial of lifestyle and dietary modifications and then go to drugs. At the moment, we usually start them at the same time. That is a consensus. Right. So sulfonylureas can be second-line drugs in resource-limited settings, especially when you don't have these new drugs like SGLT2 inhibitors and DPP4 antagonists and GLP-1 agonists, which we have talked about in detail in the long case discussions. Now, pioglitazone is another drug that we commonly use, and I told you the most important problem with these drugs is that they cause fluid retention and should be avoided in patients with heart failure and kidney failure, right? Fluid retention is the most important side effect of this medication, right? And remember, management of diabetes in the elderly with oral medication is slightly complicated. You should avoid long-acting sulfonylurea. That is a key point there, right? So in patients who are elderly, you should avoid long-acting sulfonylureas like glibenclamide, because they have a very high tendency to cause hypoglycemia. Very high tendency to cause hypoglycemia. We should avoid glibenclamide in elderly people. Okay. Any questions about these drugs? There are more MCQs on drugs. Okay, so I'll talk about them as well. Okay. The sixth MCQ, true or false, regarding management of type 2 diabetes. Sulfonylureas stimulate insulin release from beta cells, and that is the mechanism, right? That is the mechanism. Right. Now, in the long case discussions, I talked to you about the newer drugs for diabetes, right? And I told you that there is a increased interest in GLP-1 receptor agonists, increased interest, right? Liraglutide is an example of a GLP-1 agonist. Now, these drugs, most of them, write this down if you don't know, GLP-1 receptor agonists in use at the moment, most of them are injectable preparations. Most of them are injectable preparations. There is one drug which can be taken orally, but most of them are injectables. But these injectables can be given once a week. So that's advantageous. Once a week, you can use these drugs. Right. Now, the main reason why people are talking more about GLP-1 agonists is that they have been proven to have a beneficial effect on cardiovascular mortality and morbidity. Right? That is the main reason why we are talking a lot about these drugs. Another reason is, please write this down, another reason, if you remember, is they are weight neutral or cause weight loss. Right? Remember, this GLP-1 thing causes a satiety signal to the brain, right, when it's elevated. Right. And also, these drugs actually increase the postprandial insulin surge as well. That is another added effect of these drugs, right? Because this molecule GLP-1, the main action in physiology is to increase the postprandial insulin surge. So that is the main action of this molecule. So these are the beneficial effects of GLP-1 and the points that you need to know. So they are injectables once a week. There is an oral preparation also of one particular drug, right? And then they increase the postprandial insulin surge, right? And they have a good cardiovascular protective effect, and they promote weight loss, or they are weight neutral. Right? These are some of the advantages of these medications, right? Okay, so that's about GLP-1 agonists, right? And then the other drug which has come out in a big way over the last few years is SGLT2 inhibitors, right? What they do is they cause glycosuria, and they block the sodium reabsorption in the kidneys, right? SGLT2 inhibitors block sodium and glucose reabsorption in the kidneys. So they cause excretion of glucose, glycosuria. And again, write these down. There are certain beneficial effects of these drugs. Number one, again, they have a good cardiovascular mortality, right? Cardiovascular mortality, good cardiovascular mortality benefit. They have been shown to reduce progression of diabetic nephropathy, right? But these are hot topics these days, right? So SGLT2 inhibitors can prevent the progression of diabetic nephropathy, right? And thirdly, they are, as I told you in the heart failure discussion, they have effects or benefits in heart failure as well, right? So multiple, so cardiovascular risk protective effect, they are good in patients with heart failure, and they also reduce the progression of diabetic nephropathy, right? So these are all beneficial effects of SGLT2 inhibitors. The problems of these new drugs, GLP-1 agonists, pancreatitis is the problem, causes acute pancreatitis as a side effect. SGLT2 inhibitors, as you can imagine, they are excreting more glucose in the urine. So the urine is very prone to bacterial infection. Wherever there is good glucose and nutrients, bacteria will infect. So they have a higher risk of genital infections. And this can be a troublesome problem for most people, right? And this is one of the reasons why some people don't tolerate these drugs. They get a lot of genital infections, and also they get polyuria, hari amaru samahara doga ganna. Right. So that's about the newer sort of trends for diabetic drugs, newer drugs. Right. But in the West and people with lots of resources, people are now prescribing these drugs a little bit more, but they have not gone over metformin. So metformin is still by far the first line drug, but we also use these other types of newer drugs now. Right. Now, the last MCQ statement is about glycemic targets, right? So glycemic target, again, the glycemic target should be individualized, right? And you go for a glycemic target of 6 or whatever, you need young patients, right? Young, recently diagnosed people. And please write that down if you don't remember. We do not go for a strict glycemic management in people who are elderly, right? That is very important. You don't go for a strict glycemic management. People who are elderly, people have a lot of comorbidities and organ failure syndromes. You're very, very careful with their HbA1c. You don't drop it too much, right? That is an important principle. Right. Okay. Any questions about the diabetes drugs? Right. Then just a quick reminder about insulin. මෙන්න මේ slide එක බලාගෙන යන්න. මේකෙම I have given you the various sort of timing of action of insulins. And also we went through this in the long case, various types of insulins. Now remember that in type 2 diabetes, the trend now is to use, to manage initially at least with the long acting insulins, right? That is the standard of care now. We try to manage initially with the long, when you're on orals and that's not working very well, we sort of put in the long acting insulin. That is the main principle. Right. And sometimes use soluble insulin directly in very specific indications, specifically in things like sepsis and acute MIs. We use soluble insulin quite commonly, or short-acting insulin. Right. Okay. Right. Any questions up to now? So we've talked about diabetes, the differences between type 1 and type 2 diabetes, and also discussed the sort of medication that you use for type 2 diabetes. Right. Now, the next few MCQs are based on diabetes complications, and diabetes-related complications. So this sort of gives you a timeline of the development of these complications, right? Usually, microvascular complications start about 4 to 7 years from the onset of disease. Actually, in both type 1, type 2, 4 to 7 years, but they start developing the microvascular complications. They start developing the macrovascular complications a little earlier than that. They make a bars wage pain or slide complicated slide. So 4 to 7 years usually they start developing the microvascular complications. Macrovascular complications can develop earlier. Right. Now, talking about the complications of diabetes, microvascular complications, right? Microvascular complications. Diabetic retinopathy is characterized by microaneurysms and dot and blot hemorrhages. That is true, right? So at the non-proliferative form, this is what you get, right? Now, again, I told you that established diabetic nephropathy usually takes about, it definitely takes more than 5 years for this to start. Right, more than 5 years diabetic nephropathy from the onset of diabetes, not from the day of diagnosis. Remember, from the onset of diabetes, it takes about 4 to 7 years and maybe about 5 years plus for them to get most of the microvascular complications, including diabetic nephropathy. So within 5 years, 5 years right. And in the long case, I also mentioned that um, right? Retinopathy is the one that comes before diabetic nephropathy, right? So the diabetic retinopathy occurs before diabetic nephropathy, right? And a good way of deciding, say if you have a diabetic patient who presents with nephrotic syndrome, nephropathy, uh, it's an important thing to look at their fundi. Because if they have retinopathy, it's very, very clear that the nephropathy is due to diabetes. But I have seen a patient once, and this is why I say clinical examination is very important. There was a diabetic patient who came with nephrotic syndrome. And everybody was saying, no, no, this is diabetic nephropathy. But we challenged that diagnosis because the patient didn't have any retinopathy at all. No retinopathy at all. Right? And ultimately, the patient had myeloma-related nephrotic syndrome. Right? So you have to be very careful. If somebody comes with diabetes, has nephropathy, but nothing on the fundi, then you have to be suspicious. Could this be something else? Right? Because often, in almost all cases, it is the retinopathy that comes first, right? And then the nephropathy, right? Now, neuropathy, there are various types of neuropathies, right? The commonest type of neuropathy is this distal symmetric neuropathy, right? And it's often painful as well, right? Of course, diabetes can cause other types of neuropathy like mononeuropathies. We talked about this third nerve palsy, sixth nerve palsy, mononeuropathies. It can also cause autonomic neuropathy. Right. Now, this is not very important either. I'm just trying to highlight an important point here. I mean, you don't need to remember the names of the trials, but there are lots of glycemic control trials, right? DCCT and UKPDS are the sort of classical gold standard trials. DCCT is for type 1, this UKPDS is for type 2 diabetes. And there are other ones like ACCORD. Now, what is absolutely clear is that when you have glycemic control, good glycemic control, it has a significant effect on microvascular complications. Please write that down. So all the glycemic control studies are very clear in saying that if you manage these patients' glycemic control very well, they will have a significant impact on their microvascular complication. That is absolutely clear, no doubt about that. But they don't have a significant effect on the macrovascular complications. Do not have a significant effect on the macrovascular complications. That is, if you think about it, it's reasonable because diabetes is not the only thing that causes the macrovascular complications, right? So there are other factors, age, gender, right? Smoking, other risk factors that play a role. Okay, so that is why. So all the diabetes trials agree that there is with glycemic control, there is significant impact on the microvascular, but not very much on the macrovascular complications. That is very clear, obvious statement. Fine. Okay. So in this MCQ, then tight glycemic control is better, associated better macrovascular outcomes. That is false, right? That is not the only factor. You need to control other risk factors to get the effect. Okay. Mahesh, diabetic neuropathy causes nocturnal pain. So, Mahesh, most of these neuropathies cause nocturnal pain. There is no very good reason for that, as far as I know. That is a clinical pattern that we recognize. All right. Okay. Any questions about these things? So this slide is quite important because it gives you the timeline of onset of some of the microvascular and macrovascular complications. So it is about 5 years, 4 to 7 years. Right. So yes, neuropathies, established neuropathies. Yes. So some of the established neuropathies, say somebody comes with very severe neuropathic pain. Sometimes when you improve their glycemic control, the pain improves, right? So it's clear evidence that there is, when you control their sugars, the and microvascular complications improve also. So example, you come with a 6 nerve palsy or something, sometimes it gets better when you improve their sugars, right? So that is clear. But there is not a significant effect on the macrovascular complications, you can see in this table here. Okay, right. Then we go to diabetic ketoacidosis. Again, we discussed this in the emergency medicine classes, right? So yes, it is a high anion gap metabolic acidosis that occurs. Interestingly, the mortality of HHS is higher than diabetic ketoacidosis. The probable reason for this is that HHS is associated with type 2 diabetes, and these patients and the diabetic ketoacidosis with type 1. And these two patients are completely different. HHS is an elderly person, maybe multiple comorbidities, right? And then, so the mortality is actually higher in HHS because of the patient profile. Diabetic ketoacidosis, say young negoda, they got a mortality card because they can tolerate a lot of things. But the person HHS is a type 2 with other macrovascular, microvascular complications. Okay. And also remember that HHS has a much higher fluid deficit than diabetic ketoacidosis. Much higher fluid deficit. They are more dehydrated. And another thing to write down here is they have higher incidence of vascular thrombotic events. During HHS, they had a higher risk of vascular thrombotic events. And partly the reason is because they are so dehydrated, right? The blood is very viscous, right? Very dense. Hematocrit goda very so dehydrated. So they can thrombose, clot off very quickly. Right. So Iran is asking an important question, which is a very good question. Why don't we tightly control glucose in elderly, though it prevents microvascular complications? That's a very good question. So now Iran is challenging the point that I told you a little earlier that fine, we don't go for a very strict glycemic control in elderly, right? Elderly who have lots of other complications. Now the reason is, Iran, in the elderly, if you start controlling their blood sugar, yes, their microvascular complications will reduce. But this Accord trial showed that if you strictly control glycemia in elderly, they start dying, right? And there are many explanations, reasons even for that. They start dying. So the mortality is very high when you start controlling the sugars, right? So it's a risk versus benefit decision that you take. In elderly, you don't want them dying, no, right? But you can tolerate a little bit of microvascular complications. It's a balance there, right? But the Accord trial is the landmark trial that showed if you try to control the blood sugar very harshly in elderly people, their mortality increases dramatically. It's trial like a because people started dying. So I think we have discussed. And remember, in diabetic ketoacidosis, the main management steps. I'll just remind you that. So fluid therapy is the most important thing when you are managing diabetic ketoacidosis. Fluid therapy, that's fundamental in your management, right? And then potassium replacement is also very important. And you never use boluses of soluble insulin, right? It's always infusions. We recommended boluses, but nowadays it is not recommended. We use infusions, right? Boluses are no longer recommended. And I also told you that when you're managing diabetic, you should never ever stop the long-acting insulin, right? You have to continue that because that gives the patient the basal control. Never stop the long-acting insulin. Never. Right? We don't stop it. So you continue the insulin infusion, which is a short-acting thing, but underneath you give their long-acting insulin. That's very important. I hope you remember these points. Right. So fluids are most important. Secondly, potassium replacement, and then insulin infusion is the thing that you do. You don't need to manage the acidosis because it auto-corrects itself most of the time. Unless, of course, the pH is life-threateningly low, like less than 7, for example. Okay, any questions about diabetes? Ramai? So we're almost at the end now. Here I've given you some causes of hypoglycemia. Right? ඒවා හිතලා ගහන්න පුළුවන් ගොඩක් වෙලාවට. Right. Now, an interesting rare cause of hypoglycemia is an insulinoma. 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 How you diagnose that is, they present with hypoglycemia, and you have to do something called a prolonged fast. Right? Prolonged fast, so observed fast. Right? You might have seen patients being admitted to the ward for this. So observe fast, එකක් කරලා, when they develop symptoms of hypoglycemia, you send off their insulin and C-peptide levels, right? Insulin and C-peptide. And obviously in an insulinoma, these insulin and C-peptide levels will be elevated, right? That is the diagnosis there. Also remember that this classical case that you've heard of in Sri Lanka, sulfonylurea administration can also cause increased insulin and C-peptide because it stimulates the pancreas to produce insulin. අනිවාර්යෙන් case එක ගැන අහලා තියෙනවනේ. The PRIS case, so that is sulfonylurea causing stimulation of the pancreas to cause insulin and C-peptide elevation. Right. එච්චරයි ගැන දැනගන්න මහ ලොකුට කලබල වෙන්න එපා. Right. Okay. Now we talk about hypercalcemia. I've given you a table of all the causes of hypercalcemia, but I just want to focus on one single point here. Now, at your level, at an undergraduate level, you have to recognize the hyperparathyroidism related hypercalcemia. That is the most important thing to remember, right? You can clearly diagnose කරගන්න පුළුවන් වෙන්නේ. Hyperparathyroidism related hypercalcemia. Yes, ඒක තියෙනවා. Right. In hyperparathyroidism related hypercalcemia, right, or primary hyperparathyroidism related hypercalcemia, the calcium goes up, right? Obviously, hypercalcemia. But remember, the phosphate goes down, right? So an easy way to diagnose hypercalcemia due to primary hyperparathyroidism is calcium going up and phosphate going down, because that is what the PTH does. The PTH does. That is very important. Please remember that and write that down. Hypercalcium is a complicated topic, but if you remember that, I'm more than happy. Another cause of hypercalcemia is malignancy. In malignancy, remember, both calcium and phosphate will be high, right? Both will be high. If it's a primary hyperparathyroidism related hypercalcemia, the thing will go in opposite directions. Calcium will go up and phosphate will go down. Right. Now this MCQ is on primary hyperparathyroidism. So primary hyperparathyroidism is due to adenoma of the parathyroid gland. It's true, right? And you might have heard of this classical stones, moans and groans right? They get renal calculi, abdominal pain, and constipation as common presentations. As I told you, they have high calcium and low phosphate. That is one of the easiest ways to diagnose. And because hyperparathyroidism, there is bone resorption, their ALP is elevated, right? Their ALP is elevated. Okay. And if you look at an X-ray of these people's hands, this is called subperiosteal resorption, which is quite typical of primary hyperparathyroidism. And in the skull, you get something called a salt and pepper appearance of the skull, right? And very small little lesions in our skull. Salt and pepper appearance. Again, this is subperiosteal resorption. Okay. And remember that the treatment of this is surgery, and you do surgery in symptomatic patients. But sometimes you might do in asymptomatic patients, depending on certain things like a very high serum calcium level, if they have renal failure, or they have bone mineral complications, right? So the management is surgery in symptomatic people, but if they're asymptomatic, you might still consider surgery if their calcium is, say, more than 3. Values on calcium more than 3, and they have low GFR, or they have bone mineral problems, right? Bone problems. And don't worry about this hungry bone syndrome. So rapid decline in bone mineral density is an indication for parathyroidectomy. Now, the opposite of hyperparathyroidism is hypoparathyroidism, right? And there you get low calcium, high phosphate. That is an important thing, right? So, the calcium phosphate, that is an interesting way of diagnosing a parathyroid problem, right? So, if you have hypocalcium and hyperphosphatemia, right, that might be due to hypoparathyroidism, right? So, hypoparathyroidism, they have features of hypocalcemia, like Chostek sign, Trousseau sign. You have seen this very commonly in thyroidectomy, post-thyroidectomy, right? Post-thyroidectomy. And remember, when you have hypocalcemia, the QT interval is prolonged on the ECG. Right. ඉතුරු ඒවා නම් ඉච්චර වැදක් නෑ. ඒවා ගැන මම අද මේ විභාගේ ළඟ තියාගෙන ඔයා වැඩි කතා කරන්නේ pseudo hypoparathyroidism මේ වගේ දේවල් එච්චර ඔයගොල්ලෝගෙන් අහන්නේ නෑ දැන්. බය වෙන්න එපා. Don't worry. Right. Okay. Any questions? Sarangani.
Yes, sir.
Unfortunately, I had to go in 5 minutes time. So, but we can do the best response. Abhi yet kare na hai, but we can do those next day, ne, before we start. Yeah.
Okay.
Is
sir,
that okay?
Okay, sir. Tomorrow, right?
Sorry, yeah. Oh.
Yes. That's okay.
Right. Okay. Right. So I think we have covered endocrinology to the point of what is needed for your exam. Endocrinology is a very big and difficult topic, but I think I have covered the important things to go for the exam next week. March 11th. You know. So I think these are the things that we commonly ask. So if you start from yesterday, we talked about pituitary disease. Then we went on to talk about thyroid disease, hyper and hypothyroidism, even good at MCQ areas. Adrenal gland, again, Addison's disease, Cushing syndrome. We continue that today, talking about pheochromocytoma as well. So, diabetes can MCQ and it's important, obviously, long case as well. The last few things, not very important. It's very rarely that they ask about hypercalcemia, hyperparathyroidism, but manikang basic cure. Right. Treatment of hypoparathyroidism depends on how bad the patient is symptomatically, right? Sometimes the mild symptoms, a little bit of tingling, you can give oral calcium, but if they have long QT and cardiac problems, remember when there's long QT, they can develop arrhythmias. If that is the case, you have to give IV calcium, right? And sometimes there is odd phenomenon where hypocalcemia can be associated with hypomagnesemia. And if you don't correct magnesium, it won't improve at all. Hypocalcemic improve in it, right? But those are slightly advanced concepts. Right. Any other questions? Sarangani, I just remembered that another thing I usually last time I did was I did a best response MCQ paper. Again, nothing to do with the exam questions that you are getting. Okay. But for practice, just ask around if people are interested. I can do that, but keeping in mind it will be relatively close to the exam if we do it. So probably we try to finish things Wednesday. So if you're interested, I can do a paper for you next week if you like. Again, next week and Saturday or even end of the week. But ask the people. Some people, if they think they'll get depressed before the exam, some people don't like it. But if you are interested, I can do a paper like that. Best response. If you like. Right?
Okay, sir. I think most will work.
Yeah.
I'll just ask them.
Right. Just ask around and see people if they don't want, they can not come. No, but it's a bit close
Yeah.
to the exam, keeping that in mind. Right?
Hi.
Right. But I will definitely try my best to finish everything by Wednesday next week. Right?
Okay. And
So
also,
tomorrow we'll do. Oh, tomorrow we'll do nephrology. I forgot to put the questions up. I'll put the questions up now.
hi, sir. And there was also one